Hi, welcome to Johnston Health Talk. I'm Liz Thurston, Physician Liaison with Johnston Health. Today we have a wonderful show for you. We have Dr. John Guha, who's an emergency medicine physician with Johnston Health and Southeast Regional Medical Center. He comes to us today with many years of experience at Johnston Health, serving 10 years as a medical director of the ED there, and also serving on many committees within our medical staff. Thanks for joining us today, Dr. Guha.
Thank you.
So we have a great show today to talk about many things, health-related topics. And one of the most important things I think that we should touch on is emergency medicine and kind of what does an emergency medicine doctor do and how is your training different than other physicians?
Most emergency medicine doctors, of course, have gone through college and medical school, and then they have a one-year internship and usually a 2 to 3 year residency program after that. And then they can actually start practicing independently.
Okay, and so working in the emergency department, you see a range of medical issues that come in. I know something important that you wanted to talk about is when to come to the emergency department and when we should just wait and call our primary care doctor.
Yes, I think the first thing to remember is if you have any doubt, it's always better to err on the side of caution and come to the emergency department. I think in general, if a person has symptoms that have lasted more than, say, a week or two, and if they've been stable, then they may want to call their doctor first. However, if somebody's been ill for a week or two and they've been getting worse, progressively worse during that period of time, then they should seriously consider, either going to the ER themselves, if they have someone to drive them, or to simply call 911 and go in that way.
Yeah, and that service is available everywhere.
Right.
The ambulance will take you where you need to go. And I know a lot of times people think, well, they want to get a loved one to give them a ride to the hospital as opposed to calling 911. But, I mean, it's important to maybe have 911 come, or emergency come, because they can stabilize you till you get to the emergency department.
That's right. If someone's particularly ill, that stabilization, even if you're only 10 or 15 minutes away from the nearest ER, can make a big difference.
What kinds of things should we kind of wait and call our doctor the next day, or maybe call their emergency service at the private practice as opposed to going to the ED?
I think it depends on signs and symptoms. I think a low-grade fever and a cough, or maybe a sore elbow from playing tennis, or maybe even a twisted ankle, but that you can walk on without too much pain. Those are the kinds of things that usually can wait, and so you can call your doctor and kind of run the symptoms you're having by your own doctor or a screening nurse to help you decide if you need to go to the emergency room right away. However, symptoms such as chest pain, shortness of breath, weakness on one side of your body, those kinds of things that have occurred fairly quickly or that are unusual for you, those are the times that it's important to just call 911 or have someone reliable bring you in.
Yeah, better to be safe than sorry.
Right.
Yeah, and talking about chest pain and some of those symptoms, we wanted to talk about heart attack and stroke sign and symptoms. Mm-hmm. So what are some of the things that we should look for in signs of a heart attack?
First of all, heart attack symptoms can vary tremendously. So what I'm about to talk about is just the classic symptoms. And then I can kind of touch on how they can vary.
Okay.
The classic symptom of a heart attack is chest pain. It's usually crushing, dull chest pain, frequently described as a heavy weight sitting on a person's chest. Other symptoms of a heart attack could be shortness of breath, breaking out in a sweat, and these symptoms can tend to occur early in the morning, the early morning hours, sometimes waking the person up. But now some people don't have those classic symptoms. Especially people with diabetes, they may not have any chest pain. They may just have a little discomfort. They may just have some difficulty breathing, may or may not even break out in the sweat, and unfortunately they could also be having a heart attack. Mm-hmm. So it kind of depends on the circumstances.
And women have different signs than men sometimes with a heart attack?
They can. I think once women reach the age of menopause in their mid-50s, mm-hmm. they actually catch up to men in their incidence of heart attacks. Before menopause, actually, the female hormones are somewhat cardioprotective, meaning it reduces the chances of heart attack in younger women. But again, that's not a hard and fixed rule. I've seen women in their 30s and 40s have a heart attack. Wow. It's rare, but it can occur.
Yeah, and as we get older, we think about it more often because you're like, gosh, you see friends and loved ones going through things like that, and we
Right.
want to be aware of the things that we can look for as we get older or younger, to make sure that we're getting the care we need if
Right.
those symptoms start to happen. Now, is it true if you take an aspirin, is it with a heart attack that it would, is that
Yes.
with stroke?
No, with a heart attack,
Okay.
if you think you actually are having a heart attack and you're not allergic to aspirin,
Okay.
then chewing up 3 or 4 baby aspirin right away would be a good idea. Not a coated aspirin, because a coated aspirin won't take effect right away.
Okay.
Chewing up baby aspirin, which usually tastes fairly good. Keep a bottle of cherry-flavored baby aspirin in the cupboard. That can reduce the severity of the heart attack,
Okay.
as much or more so than some of the medications that we give in the ER. The key there also is to get it on board early, to chew that aspirin up early. If you're not sure and you're not allergic to aspirin, chewing up 3 or 4 baby aspirin is really not going to hurt you.
Okay. And to be honest, I mean, as I get older and my husband gets older, I do think about a heart attack possibly happening to one of us. And I bought some aspirin just to keep at the house. It's not something we normally take, but just in case, again, better safe than sorry to be
Right.
able to do that till help gets there.
Right, that's a good idea.
So, and now stroke on the other hand, so heart attack is more your arteries kind of clogging up. The difference
Yeah.
between heart attack and stroke?
Yeah, in a heart attack, basically there's several arteries that kind of sit on top of the heart muscle and supply the muscle with its own blood supply. When one of those arteries, as you say, plugs up, we say occludes, with a blood clot, a small blood clot, part of the heart muscle then isn't getting blood suddenly, and those muscle cells begin to die. That's a heart attack in plain English, is death of the part of the muscle cells due to the plugging up of one of the heart arteries. As opposed to stroke, where it's a similar process, but it can be a small blood clot that lodges in one of the arteries supplying the brain, and then the brain cells begin to die. Okay. And depending on where in the brain that occurs, it can give different symptoms of different types of strokes.
Okay. And what are some of the symptoms of a stroke?
Again, I'll mention kind of the classic hallmark symptoms, but there's a lot of variability. The classic symptom is weakness, sudden weakness on one side of the body. It could be just the arm. It could be the face, that half of the face in the arm. It could be the face, arm, and the leg. Again, it depends on where the blood clot is in the brain that occludes that artery. Okay. That is probably the hallmark, is just a sudden onset of weakness, inability to move, or completely would be paralysis, or just weakness of one side of the body.
Yeah, and I think I read something, there was an acronym, FAST, that were some of the things that, a way to remember what the symptoms are. And it was face drooping, arm weakness, which you mentioned, speech difficulty, and then call 911.
Right.
So that was kind of the acronym for us people that don't know the medical terminology to kind of remember and look for. So definitely we need to keep all of that in mind.
Right.
Are there any typical, non-typical symptoms that you should mention as well?
Of stroke?
Stroke, yeah.
Yeah, sometimes it could just be, and you mentioned it in the FAST little quip there, it could just be speech. You could not have actual weakness, so that is important to realize. If someone suddenly develops slurred speech, even though there's no weakness of the face, arm, or leg, that could be a stroke. So that is one of the classic things to look for.
And so if I'm with you and you're having a stroke, some of the things that I could do, maybe you don't realize you're having a stroke, but I see that some kind of things are going on. Is there a way that I can better assess that situation, or do we just go ahead and call 911? We know something isn't right.
Right. I think, again, the first thing to assess would be speech, to simply talk to me and see if I can talk back clearly, if I'm oriented or not. And then the second thing would be to have me move my arms, move my legs, and see if they're moving normally or not. I think those would be the two major things, is speech and movement of the arms. Make sure they're the same from right to left. Same thing with the legs. They should be pretty much equal on both sides. If one side's much weaker than the other, then that's the time to call 911.
So with both chest pain, or heart attacks I should say, and stroke, So now I've taken the ambulance, I'm at the emergency department. You as a physician, what happens when I come into that emergency department? Am I brought directly back to the emergency room? What'll happen as a patient?
Okay, well, if you're having those symptoms of either a heart attack or a stroke, usually you get placed in a room right away, and then one of the emergency room nurses will screen you, meaning they'll take your vital signs and talk to you a little bit about what symptoms you're having. And then depending on the severity of your symptoms, then they will notify or alert one of the ER providers, and that could either be a PA, physician assistant, or a nurse practitioner, or the physician themselves. And then one of those providers will come in and begin to assess you. And that should all occur within a matter of minutes.
Right.
And then certain tests will be ordered. Of course, the provider will talk to you also and examine you and order those tests. In the case of a stroke, a CAT scan of the brain would be in order. Sometimes certain hospitals such as Johnston has a protocol where if the ambulance calls in a patient with symptoms of a stroke and they haven't even arrived to the ER yet, they will alert the CAT scan department,
Okay.
and sometimes immediately go to CAT scan as soon as they enter the hospital. So it speeds up the process of making the diagnosis. And then the physician or the provider may see that patient after they've already had their scan.
Yeah, and I know that Johnston Health is chest pain accredited at both facilities, and I'm sure all hospitals around the area are able to treat and take care of those patients that come there, whether it be Johnston or other facilities in the area. Now you work at Southeast Regional Medical, and I'm sure you're experiencing the same things there.
Yes, I think it's similar. I think in any hospital, at least in this area, in North Carolina, that I know of, any hospital over a certain size, they would handle it the same way. They would handle both stroke and heart attack patients the same way.
Wonderful. And what are some of the other things that you see come through the emergency department, or some information that would help better educate our patients to have a good experience? I know one of the biggest things are wait times, but
Yes.
we're all working on that.
Yes, I think one of the biggest misconceptions is that if you come in by ambulance, that you will get seen sooner by a provider. That's not how it works. How it works is the nursing staff will assess you when you arrive, unless you're having clear-cut symptoms of a stroke or heart attack. Mm-hmm. But if you're not, then usually the emergency department nurse will assess you. I've seen, unfortunately, people come in with a twisted ankle on an ambulance. Those patients will go out to the waiting area and wait their turn. So it really kind of depends on what symptoms you're having. So I think it's important to realize that if you're not having symptoms that you think are really life or limb threatening, there's a good chance you may have to wait somewhat to get seen.
Right. And so that process that you're talking about is what we call triage. And
Right.
so the nurse assesses you, they take all your information, and then determine if this isn't real emergent, you can wait a little bit and be seen as you arrive. Whereas if it's more severe, you're going to go straight back, and somebody will take care of you. Obviously, if it's a heart attack or stroke, it's going to be right away.
Right. And I think it's important to realize that if someone shows up, just walks into the registration part of the ER with symptoms of a heart attack and stroke, they'll also be taken back quickly and seen quickly. Mm-hmm. If someone comes in on an ambulance with a twisted ankle, they're going to switch places basically with the person that came into registration. Right. So you're right, it's the severity of the symptoms and the triage process that follows that will determine how quickly you get seen.
Dr. Guha, one of the big subjects lately, I've actually talked with another physician in Johnston County that's part of this program for the Lazarus program, which is pain medicine and taking your medicines properly and disposing of them when you no longer need them, or even addiction and that help to get from whether it's narcotics or another form of addiction. Are you seeing a lot of that in your travels to the ED, working in the ED?
Yes, unfortunately I am. I think there are individuals that have chronic pain and individuals that have acute pain. And the difference is if you fall and break a bone, that is acute pain, and that's what we treat primarily in the ER. Mm-hmm. People with chronic pain, such as, say, chronic low back pain or severe arthritis even, that have already seen their physician several times, and possibly have begun to take narcotics on a continual basis, those are the patients that probably shouldn't come into the ER unless something has changed. If someone has back pain, they've had it for years, Now suddenly that pain is going down one leg and that leg's getting weaker, or they've lost control of their bladder because the nerves from the lower back also go to the bladder.
Okay.
That's different. So if there's chronic pain, but then suddenly there's a change in that chronic pain, we would consider that to be acute pain, same as acute pain. And acute pain, again, is usually due to either an injury or some other illness that has caused pain within the last day or two or three. And those patients will probably get seen sooner.
Okay. And so are you seeing, I guess more with chronic pain when people are having to take pain medicines all the time because they're in pain, that there's an addiction factor there, that people are, not able to get off some of their medication because of that?
That's very true. I think in emergency medicine we kind of walk a fine line regarding patients that are on chronic narcotic medication, such as Norco and Percocet and others similar to that. There's a lot of addiction out there for various reasons. And so we tend to be, I think, fairly conservative in the ER of promoting or promulgating narcotic addiction. Mm-hmm. So if we see someone that has come in that's been on narcotics for a while and there's been no real change in their pain pattern, we hesitate to write prescriptions for continued narcotics in those patients for two reasons. One, they can become more and more addicted, and two, it encourages the behavior of episodic care in emergency rooms rather than following up and get good continuity of care with their own physician.
Right, which is so important to, no matter what, when you go to the emergency department. I know that when you discharge, you always recommend follow up with your primary care, and it's so important to do that and get your annual exams and really just be sure that your health is on track on an annual basis if there are no issues throughout the year.
Yes.
So, and if there is, to take care of that and make sure, and take your medicines when prescribed if there is an issue, because, and as prescribed.
Yes, I think those are all good health habits to have, and I think if more people had those, I'd probably be out of business or
right.
have a lot less business. So I think that it's health maintenance, basically. Health maintenance is, if not as important, maybe more important than emergency care. So if you have to see me, then unfortunately the horse is out of the barn and there's something wrong. Now, having said that, you can have great health maintenance and do all the right things and get appendicitis.
Right.
And have to see me and then have to see the surgeon after me. So, health maintenance obviously decreases the chances that you'll need to seek emergency care.
So a little kind of go back to the beginning, some information about you. So what made you choose emergency medicine?
Several reasons. I think most emergency medicine providers are, to be blunt about it, adrenaline junkies.
Right.
There's a lot of excitement in the emergency room. Things can change from minute to minute or hour to hour. There are periods of where it's slow, sometimes at 2:30 or 3 in the morning, which is, I was in the ER at that time this morning. It was relatively slow, but then suddenly, things will change and we'll get 3 ambulances in at the same time. Mm-hmm. And and those patients may be very ill, and then I'm suddenly juggling 3 or 4 balls at the same time. But I enjoy doing that. That's what I'm there for, and that's what I'm trained to do.
And you studied, where did you get your medical degree from?
I got my MD from Boston University.
Okay. And you also served in the Corps for a while?
Yes, in the Air Force.
Okay.
Yes, I was in the Air Force Medical Corps for 4 years. I was actually on a scholarship. They put me through medical school.
Oh, wonderful.
And served in Florida and in North Carolina, and that's how I ended up at Johnston.
Wonderful. Well, thank you so much for joining us today and giving us all this wonderful information. I think it'll be beneficial to all our viewers, and hopefully people will come to the ED when they need to and see their primary care doctor when they need to.
Yep, they sure will. Thanks so much, Liz.
Thank you so much.
All righty. Bye-bye.
Bye.